I'm very privileged to be here with my colleagues and our friends from Egypt. نورتوا عمان. أهلا وسهلا فيكم. بالمحاضرات اللي قبل اليوم الصبح وامبارح كل الناس كانت صاحية. I don't know which one looks like Mr. Bean. في واحد هون بس مش رح أحكي من هو. للأسف أنا I'm the last speaker فبدي إياك تكونوا صاحيين معي. الكل صاحي؟ Constipation. الناس حكوا على الديسبايوسيس وعلى RNA, micro RNA وعلى early gastric cancer. I was left with a boring topic. Or is it really boring? على فكرة constipation is not for humans. حتى الانيمالز ممكن يصير عندهم constipation. So بنحكي احنا عن resistant chronic constipation. شو يعني chronic constipation? It's simple. It's chronic. It's been there for a long time. وفي عندنا مشكلة بالfrequency, either frequency إنه بروح الحمام أقل or difficulty in passing stool. شو يعني resistant chronic constipation? Which is we commonly see. بس أي واحدة basically it means temporary or minor relief. مريضك مش مبسوط. This is not uncommonly we see it in our practice. We tend to forget it because it's bad experience for us. We only remember the difficult patients that managed well or we dealt with the cases. But the simple nagging cases we tend to forget. This is human nature. But those patients will be distressed, uncomfortable, anxious, will get frustrated. By human nature, doctors like their patients to get better. If they don't get better, they're either difficult patients, hysterical patients, something wrong with their brain, حل عن سماء go somewhere else. طبعا بهاي الحالة بيكون عندنا الدكتور زعلان، مريض زعلان، والمريض راح يروح يحكي للناس عنك. احنا الأردن smaller country than Egypt, almost everybody knows everybody, so people will know that you're a bad doctor. So سؤال الجائزة للي بيعرف الجواب علبة ريزولور لمدة شهرين.
السؤال شو الجائزة؟
علبة ريزولور. What percentage of patients are dissatisfied with conventional constipation treatment؟ يعني من المرضى اللي بيراجعونا قديش النسبة اللي ما بكون مبسوط. على فكرة احنا يمكن we don't see them again or we don't realize that they're dissatisfied. 5%, 15%, 25% أو 50%. والجواب 50. Almost. هي أي واحدة تبعت الليزر. Almost all patients with constipation will try treatment لأنه it is something not nice to them. I'll show you why soon. But half of them are not happy with that what they're treated with. فدكتور عماد من كل two patients, one patient is dissatisfied. Okay. Many things they're not happy about, as you can see: ineffective bowel relief, lack of predictability, etc. هلا شو الميثs about constipation؟ في شيء اسمه myth وفي شيء اسمه truth. We want the truth. Is it simple? Is it caused by stress? Is it usually there's an underlying cause, hypothyroid, abdominal surgery, etc. It is to be primary constipation uncommon, not a real disease, minimum impact to quality of life. So what, you're constipated, go and live with it. Caused by poor diet, eat more fibers, exercise, improved by the change of life style modifications, and there's a wide variety of effective treatments. طبعا الجواب لهم كلهم لا. Constipation is highly prevalent, up to 15%, يعني 1 out of 7 of the population have constipation. It's higher among women, older adults, and lower socioeconomic status. زي ما احنا شايفين. How common is it? It is probably as common as all other diseases that doctors encounter. Well, the interesting thing is that why I put this study, because in this study it says that 43% who reported a chronic constipation remained constipated. يعني المرضى هذول رح يضلوا بوجهك. You will keep seeing them all the time. They want good management. Impaired quality of life. Many studies that show it does impair the quality of life, and the quality of life these days is very important marker in our management for our patients. How their life is affected by their problem. They have lower physical activity, lower mental components, they produce less, it affects the whole community. The cost, definitely patients with constipation will use their health services more, and they'll miss work, they'll miss school, they're less productive, so it's a very complicated issue. And I put this slide because it's important comparing. There's a lot of talk about chronic constipation and IBS dominant constipation. People with chronic constipation tend to spend more money on their health issues than people with IBS dominant constipation or IBS in general. I put this study as well to show that the problem is getting worse and worse. Ladies visiting emergency departments with constipation in the US, the number has increased, and it will increase more and more. So we'll see more and more of those patients. When we talk about any functional bowel disorder, we have to talk about the Rome criteria. The Rome committee is a committee of experts who meet frequently in Rome to talk about functional bowel disorders. طبعا, the main one is irritable bowel, but there's quite few of them, as you can see. The Rome 3 criteria for diagnosis of constipation. Rome criteria is mainly to conduct studies, to standardize symptoms so you can do studies, but we usually use it in our clinical practice. So the symptoms have to be there for 6 months. This is the duration to be chronic. And there should be active symptoms over the last 3 months. مش إنه إذا كان عندك مرة constipation قبل 6 months, يعني you have chronic constipation. There should be active symptoms. And there should be 2 of the following, and this is very important: straining, lumpy or hard stool, sensation of incomplete evacuation, sensation of anorectal blockage or obstruction, manual maneuvers needed either by digitation or by using water jet, less than 3 bowel movements per week, and this should be for around 25% of the time. The difference between Rome 2 and Rome 3 that they said now that there's loose stool should rarely be present. If there is more loose stool, you have to think of irritable bowel syndrome more than functional constipation. And there should be insufficient criteria for IBS, i.e. there should be no significant pain. If there is pain, then you have to think of irritable bowel syndrome. Rome 4 criteria, we've been waiting for it for a year now, as you know. It probably will be out in July, maybe spring or summer of next year. It will be interesting to know what kind of changes they will include in their criteria about constipation with all the new treatment modalities and all the talk about dysbiosis, etc. So in the Rome criteria, there are objective and subjective parameters, as you can see. And these can help us to, when we take the history, we should take all those points. You have constipation? No. Tick, no constipation. You should ask your patient how many times you go to the toilet. Do you strain? Is your stool lumpy? Is it hard? Do you completely evacuate? We should ask all those questions. So, because chronic constipation is a multi-symptom disease, it is not just by how often you go to the toilet. And we always should remember the Bristol chart for stool. Every doctor should have this in his clinic. This is every GI doctor, every general practitioner should have this in his clinic. Number 1 and 2 are the constipated patients, basically. And this is a very important point that doctors and patients most of the time differ in their perspective of constipation, what the word constipation means. And many studies that have showed that. This is an English proverb that says apples and oranges, يعني أشياء مختلفين زي الزمالك والأهلي مثلا. الزمالك ما زبطوش بآخر مباراة بس يلا مش مشكلة بلكي. For doctors, it is frequency. How often you go to the toilet? يعني for a doctor, the patient will say, I have constipation. And you say to them, how many times you go to the toilet? And they say, 3 times a day. And they say, كمان مريض مجنون شو بدي أعمل؟ بدي أخلص شغل اليوم أروح على البيت أرتاح. For patients, it's all about straining, hard stool, incomplete evacuation. So we have to put all those symptoms together to diagnose constipation. Maybe that's their discomfort, and if we treat it right, they feel better. So patients are more likely to describe stool by straining, hard stool, urge to pass, abdominal discomfort more than the frequency. So I'm not going to talk much about general classification, but we know constipation could be slow transient. It could be anorectal outlet abnormalities like pelvic floor dysfunction, or it depends if we're talking about constipation, we'll consider IBS-C as part of constipation. It's normal transient, but it could be different. So and the problem is there could be overlap. You could have this and this and this, or you could have this and this, or this and this. And basically, this is how you classify them. It's all about abdominal pain. The more pain there is, the more this is irritable bowel syndrome constipation. I'm not going to talk much about dysenergetic defecation and so slow transient. They're beyond the topic of this lecture, but just to remind ourselves. So basically, you have a patient with constipation, or you have a patient with anything, even itching. You have to make sure that they don't have a disaster. If you send them home, that there will not be a cancer hidden there or a heart attack or something that will kill them. So basically, with any patient, you start with history, clinical examination, and investigations. And hopefully, by taking a good history, a proper clinical examination, you would have diagnosed 90% of your patients. You leave the 10% for investigations, regardless of what it is. And when you take the history, you want to classify your patients, and you want to rule alarming symptoms. Same with physical examination and laboratory testing. Usually, most patients with constipation, they have primary constipation. There's a list of secondary constipations, but of all the constipated people that come in, how many people have secondary constipation? The number is not that significant. Drugs, obviously some drugs can cause constipation. There's a big list, and taking a drug history is part of taking a thorough history. Yield of diagnostic tests usually is not that high. The only one that people talked about, celiac disease, probably if the patient keep coming, it's very worth testing celiac disease. Celiac disease is not, as it was mentioned, it is not about just diarrhea and malnutrition and delayed growth. It could present with any GI symptoms. It could be silent as well, but it could present with constipation. And we are diagnosing patients, especially ladies, with constipation that have celiac disease. So it is a very important test to keep in our mind. We maybe defer it because of the price of it, but it should be there to think about. The other tests, I'm in the private practice. If I don't do some tests, my patient will think they won't trust me. The basic one I go for is CBC, basically, complete blood count. I might do some other tests like thyroid function, depending on the family history or the history or whatever, but we usually don't do much test. And as you know, most patients with constipation, if it's chronic, even the colonoscopy will be normal. You're not worried about cancer or etc., unless there are alarming symptoms. So basically, you have a patient with constipation, you rule out red flags, any sensitive history or examination, and then it depends on the duration. If they have less than 3 months of constipation, you treat empirically with anything, with any laxatives, and you hope that it will go away. Sometimes it does, sometimes it doesn't. Akka will be always praying that all those patients will become chronic, so there will be more and more prescriptions. If it's more than 3 months, 6 months, it is chronic. You have to make sure it's not secondary constipation, and if it's primary, you have to decide, are you dealing with IBS-C or chronic constipation? And actually, that's not that important now. In the past, there were certain treatments for IBS-C without chronic constipation, but they are withdrawn now. So all the treatments now are the same, but it's important to know where to classify your patient. So basically, advanced studies, we don't do them much, like chronic transient studies, sometimes manometry, defecography, all those tests. We keep them for the complicated tests, and we rarely do them really. In clinical practice, it doesn't matter which one you have, because treatment at the end is the same, except probably for biofeedback. So as it summarized in this study, we usually leave those tests to the end after we try everything in our hand. So, what are the goals of treatment? They're simple and obvious. Improve symptoms, so your patient will be satisfied. Accelerate colonic transient, stimulate gut motility, facilitate defecation, promote intestinal secretion. Very simple and very straightforward. But we have to remember a few things. Chronic constipation can be frustrating for both patients and healthcare. Definitely some patients do not improve, and they will keep coming back and back. And if they have the chance, they will visit many doctors. Symptoms don't always accurately reflect the underlying pathology. Slow transient patients will say that I eat a lot, but I don't go to the toilet. Maybe I can go up to 3 or 4 weeks. Pelvic floor obstruction will tell you that I strain, I don't completely evacuate. I need to do digitation to evacuate the stool. But sometimes the history is mixed, and it's not that easy. Symptoms do not predict response. The patient that will go to the toilet every 3 weeks probably will get better with just drinking more water, eating fruits, and simple laxative. And the patient with what you think is simple constipation is the one that will keep coming to your clinic. I'm not better, I'm not satisfied. And many patients actually, and you say, okay, I'm going to prescribe you this, I tried it, and that, I tried it, and that, I tried it. So most patients, before coming to you, they would have listened to their friends, neighbors, you know, in Jordan and in Egypt, people meet in gatherings and everybody, people exchange their medical experiences together and they will try anything. So probably the patients, by coming to you, they will try all the conventional treatments, and it happened to all of us. So, how do you manage those patients? You have to start with lifestyle modification. You like it or you don't like it. How much literature? You can't go without asking your patients to drink more fluids, especially water, exercise more, and eat more fibers. Maybe the patient will do all of these and still have constipation, fair enough, but you should try them. And many patients, I find, especially with exercise, and when you take the history and they say, I remember when I used to go to the gym or swim 6 months ago, I didn't have constipation, or I didn't have bowel problems. So it's very important to stress these. This slide is probably very, very important when you advise your patients, which it's very simple, but which fruits to eat. The fruit with the highest fiber is avocado. Jawfa is there, kiwi is there, oranges, mango. المرة الجاية بيجيبوا لنا معكم مانجا من مصر. كل هاي some people think that bananas they cause constipation. Actually no, bananas have fibers and they're good for constipated patients. So this is probably a good list to remember. Avocado, jawfa. What other methods you can use? أبوت ورانا حتى who wrote these papers from Abbott, his family is Abbott. Perineal acupressure, anybody heard of that? يرفع ايده. أي حد اسمع بالperineal acupressure? It's a very simple test by basically massaging near the umbilicus, below the knee bone and between the first and second toe. It stimulates bowel evacuation. It can work. I sometimes ask my patients to Google it or do a YouTube and see the exercise. It helps some patients. A lot of talk was done about microbiota and this wonderful meeting. You know, probiotics, they're still not standard treatment for constipation. They do work in a subset of patients, not a big group, but it's worth trying because it's a natural thing. So it's probably worth throwing a probiotic at one point during management of those patients. Kefir, سامعين بالكفير? Some kind of yogurt that's present in Russia and Turkey mainly. It's present in some of the Arab world, especially the Bedouins use it. It's a highly fermented yogurt, and it does help some patients as well. If people are fed up with medicines and they ask you about the non-conventional things to do. Biofeedback. Do you do biofeedback in Egypt? Yes. If anybody does biofeedback, can you please raise your hand? This is very sad actually. I have to admit we don't do it in Jordan as well. I wish even for Jansen to get us all together and let's do a workshop in biofeedback. Biofeedback is important for people with pelvic floor muscle problems. It's an important thing to do, and it's a shame that we don't it should be part of our practice. You know, even if it benefits 10-15%, but I think we need to work more and more on that. There should be a center actually, either in Al-Bashir, in Jordan, or King Hussein Medical Center, or the university. There should be one center that does that usually. And it's a simple thing to do. So, basically what conventional treatments people use, we all know that. Bulk laxatives, osmotic, emollients, and stimulant laxatives. They all come with their side effects. The stimulants, you can even get ischemic colitis. Even the ones that has mainly good literature on are the pig and the lactulose, and they still come with their bitter taste or sweet taste, or with the lactulose, the bloating, with the polyethylene glycols, sometimes the diarrhea or the electrolyte imbalance. So literature, lifestyle, few supportive data, you have to advise your patients to go on the lifestyle modifications. Laxatives, the only one are the pig and the lactulose that have proper recommendations. So where to go? We're stuck. 50% of our patients are not getting better. What should we do next? Colectomies, Dr. Ayed. Sometimes unfortunately patients go up to colectomy if their symptoms are that bad. So there are 4 options now. The only one in our region is procalcipride, Resolor. I've heard that in Egypt linaclotide is sometimes available, but on a very limited basis. But this is the one that we're really dealing with now. This is the new hope for our patients in our region. So this was a press release from Janssen in 1999, orally administered, the name of the derivative, and it's a potent selective high affinity agonist of 5-HT4. It was a small study on 12 healthy volunteers. So basically, we have to remember that we use it in adjunct to other things that we use. It's not that every patient that comes in with constipation, okay, take Resolor and go home. They should have the lifestyle modifications. They should have tried other simpler treatments first, and if that doesn't work, which is probably up to 50%, we have to think of this option. The dose is usually 20 milligrams, 2 milligrams in adults. In elderly, 1 milligram will do the job. In mild to moderate renal impairment, 2 milligrams. In severe renal impairment, 1 milligram. In liver impairment, and we see a lot of liver patients in Egypt and Jordan, it's 1 milligram, which can go up to 2 milligrams. The same with the elderly. And it's very simple, once a day, with or without food, and you will have a spontaneous bowel movement 2.5 hours after the tablet. You feel like going to the toilet. So it's very important to stress two things to your patient. Don't eat the tablet and go to bed, and don't take your tablet and go shopping, for example, because when you have the urge to go, you have to go to train your bowel how to go. So it's very important when you take it to make sure that you're near a comfortable toilet. So how does it work? Basically, if there's impaired propulsion in the colon, this is where stimulating the 5-HT4 receptor will improve that. And basically, it significantly accelerates overall ascending colon emptying half time, overall colonic transient, and orocecal transient time, and whole gut transient. So one of the reasons that prucalopride was delayed until it was licensed is because of this, because of those two medicines, and one of them was for Janssen as well. The fairly older doctors here will remember Prepulsid or Cipride and how great it was at that time, and people remember Tigacerod as well, and we all remember that why both withdrawn because of having arrhythmias or cardiac complications. And basically, why is prucalopride different from them? Because it's very selective. It only works on 5-HT4. The others worked on other receptors that could give us the cardiac complications. So even it was licensed, until now, doctors are still worried about those complications. So the safety before it was licensed, 3 big studies, 3 big figures that did studies for using the drug for 12 weeks, 3 months, and basically they're all well designed, proper, good quality studies, and they all came with the same thing, that it is a safe drug. Mainly it's a safe drug, and it does work. So it is, as we said, safe and effective. It's, as we said, about the mechanism of action, and basically it's the good thing is after giving it for 3 months, usually you could have a sustained, in most patients you'll have a sustained effect that will go for longer and longer. But in clinical practice, we find some patients that will need something else on top of the prucalopride, like PEG, for example, or maybe some patients will need to take recurrent courses of the medicine. Side effects, minimal, but you have to counsel your patients. Most side effects happen in the first day, maybe the second day. In our practice, headache is the main side effect, and if you reassure your patient that it will disappear in 2 days, and actually it does. After 2 days, there are rarely any significant side effects apart from placebo. So basically in the elderly, the 1 milligram worked the best and had the least side effects. And basically الاستشاري. And basically long Q2 intervals and arrhythmias were not an issue at all. And basically, if you stop the medicine and you use it again, there is no loss of effect or there is no rebound changes, and that happens in elderly and all population groups. 5 minutes. I like this study from 2013 because it summarizes what we have to do. It is generally well tolerated in patients. Reported adverse events happen in the first day and they usually disappear. Cardiovascular safety is definite, and basically use it in patients who are refractory or who are difficult patients. Initially it was licensed in females, but now there are studies that say it works well in males. I don't know why it shouldn't work in males, and actually people tried it. We tried it off-label, and it does work in males. Very important thing now about overlap diseases. All those diseases are becoming common, and we're seeing patients actually with dyspepsia, constipation, GERD, and IBS. They all overlap together, and even now the ROM criteria, the ROM 3 criteria started recognizing that, and it will be mentioned more in the ROM 4 criteria. So it's not very uncommon for us to have a constipated patient with reflux and functional dyspepsia. And there's a very, very important point about prucalopride, that's a prokinetic. So actually it might work, actually it does work in dyspepsia. It might work in reflux as well, especially non-acid reflux or laryngopharyngeal reflux. It might work. And that it's not licensed for that yet. There are some studies about that. And it's very interesting when you have a patient with overlap symptoms, and those patients are complicated, by the way, and they do worse. So you have to get all the symptoms and treat them separately. If you treat those patients, it's out of interest. If you've documented early satiety or bloating or postprandial distress or reflux symptoms, and you've given them Resolor or prucalopride to see if they do improve with that or not, because this is very important indication for the future. It will definitely have a role in functional dyspepsia. I'm very interested to know if it will have a role in non-acid reflux. Thank you.